Hello and welcome back to my YouTube channel. In this video, we will cover the last and final part of the three-part video lecture series of diabetes mellitus, where we'll discuss the clinical features of diabetes mellitus, the acute and the chronic complications and its appearance under the microscope. And as always, comments, healthy discussions and doubts are always welcome in the comment section below because knowledge shared is wisdom gained. So let's go. So diabetes mellitus has three important clinical features. The first is polyuria. The second is polydipsia. And the third is polyphagia. Now what do these three terms mean and how do these derangements come about? Let us see in the next slide. Now as we all know, as we all saw in the previous video lecture also, insulin by nature is an anabolic hormone. What do I mean by anabolic hormone? It is a growth promoting hormone. But what happens in diabetes mellitus? In diabetes mellitus there is insulin deficiency. So the opposite state will happen, that is there will be catabolism. Now in catabolism there will be growth inhibition, there won't be growth promotion. So because of the insulin deficiency and or insulin resistance, there is decreased utilization of the tissue glucose to the adipose tissue, to the striated muscle, to the liver and the other organs. So there is growth inhibitory effects and there is decreased tissue glucose. So the body will have to compensate for both these factors. That is why it leads to a state of polyphagia. What is polyphagia? Wherein there is increased appetite. So in our normal diet, the amount of insulin that the body gets is not being utilized in diabetes. Neither is it utilized for growth nor is it reaching the particular tissues. That is why there will be increased appetite or a state of polyphagia in diabetes, so that some amount of glucose at least through the appetite tries to reach the tissues and some amount is at least used for the growth of the body. So what happens apart from this, you must understand there is a hormone called as glycogen. Now this glycogen synthesis also decreases. Insulin synthesis decreases, so does glycogen synthesis. There will be decrease in the glycogenolysis. But what is counteractive to insulin? Glucagon. So there will be excess of glucagon. Glucagon excess would lead to increase in the gluconeogenesis. Now, increase in the gluconeogenesis will then result in the condition called as hyperglycemia. Insulin decrease, glycogen decrease and glucagon increase would lead to hyperglycemia. So what happens then? This all will reach the kidney. In kidney, there is normally filtration of glucose and reabsorption of glucose. This is a normal process. What is not normal? When the glucose filtration is more than that of the glucose reabsorption. That is, there is increased glucose which is filtered, but that much glucose is not being reabsorbed by the kidney because of the state of hyperglycemia. So what would that lead to? That would lead to glycosuria, that is presence of glucose in the urine. So that would lead to a state called as polyuria. What is polyuria? A state where there is loss of water and electrolytes. So polyphagia is increase in appetite, whereas polyuria is a state where there is loss of water and electrolytes. So what happens? You have, as a result, you have water loss, plus you also have increased amount of glucose which gets depleted. So that would lead to increased amount of thirst. Why? Because water is also lost, glucose is also depleted. So the person tends to feel very thirsty. So that would lead to a state called as polydipsia. So this is a result of the three symptoms, and this is how these three symptoms will manifest in the body. Now that we have seen the clinical features of diabetes mellitus, let us now look at the metabolic complications. We'll start with the acute metabolic complication of diabetes mellitus, which is called as diabetic ketoacidosis. Now, diabetic ketoacidosis is very commonly seen in type 1 diabetes mellitus. So, diabetic ketoacidosis is commonly seen in type 1 diabetes mellitus. What happens in diabetic ketoacidosis? There will be secretion of a hormone which is called as epinephrine. This epinephrine is also actually a catecholamine. So whenever there is epinephrine secretion, it will, as always, decrease the insulin secretion and it will increase the glucagon synthesis. So it will stimulate the synthesis of glucagon and decrease the insulin secretion. So what will happen when as we saw in the previous slide also, when glucagon is stimulated, there will be increased gluconeogenesis, and that increase in the gluconeogenesis will lead to a state called as hyperglycemia, as we saw in the previous slide. So this hyperglycemia, it would lead to increased osmosis, as we saw, this also we saw in the previous slide. So there will be increased osmosis because of this hyperglycemia, and that would lead to increased ketoacidotic state. So apart from your polyuria, polydipsia and polyphagia, there is also increase in the ketoacidosis. Now what happens is, because of this ketoacidotic state, what do we mean by ketoacidotic state? There will be increase in the ketone bodies. So there will be increase in the ketone bodies. Now this ketone body increase is also due to the stimulation of this particular enzyme called as lipase. So when there is increase in lipase, there is increase in the ketone body secretion. So there will be increased circulating free fatty acids. There will be increased circulating free fatty acids. So this will then stimulate an enzyme called as fatty coenzyme A. Now this enzyme called as fatty coenzyme A, it will reach the liver. So when it reaches the liver, there will be an oxidation to ketone bodies. So whenever this ketone body gets oxidized, that ketone bodies will then start increasing in the body, because the more the lipase, more the free fatty acids. So increase in lipase, increase in free fatty acids, increase in fatty coenzyme A, increase in ketone bodies, and these ketone bodies will start developing in excess. Now this would then lead to ketonemia and ketonuria, that is increase of ketone in the urine and increase of ketone in the body. So that would then lead to dehydration. So when it leads to dehydration, there is a complete syndrome which is called as metabolic ketoacidosis. It would lead to development of this syndrome which is called as metabolic ketoacidosis. So what happens if we treat diabetic ketoacidosis? even if we treat the diabetic ketoacidosis, say there is no more diabetic ketoacidosis due to treatment, then also the patient will then develop hypoglycemia. So without treatment, diabetic ketoacidosis is the most common complication. With treatment, hypoglycemia is the next common complication. So now that we have seen what are the acute metabolic complications of diabetes mellitus, let us look at the chronic complications of diabetes mellitus. The first is diabetic macrovascular complications. Diabetic macrovascular complications are those that occur in large and medium sized arteries. Diabetic microvascular complications are those that occur in small sized arteries. We must understand that diabetes mellitus or its complication is not solely due to hyperglycemia. Like we saw in the previous videos, it is also because of insulin resistance, obesity and several other factors. Now, there are four major mechanisms that underlie the complications of diabetes mellitus. The first is formation of these advanced glycated end products. What do I mean by advanced glycated end products? Whenever in hyperglycemia, there will be certain metabolites of glucose that will be formed because of hyperglycemia. Now these will interact with proteins, whether intra or extracellular, and they cause something called as advanced glycated end products. Now these advanced glycated end products work with a receptor. It also works without a receptor. So when advanced glycated end products react with a receptor, they tend to cause four major effects. First is release of TGF beta and VEGF. This TGF beta, once it releases that, these two are cytokines as we know. Now this TGF beta, once it releases, it leads to deposition of the vascular smooth muscle. And VEGF is the main reason, one of the main reasons why there is diabetic retinopathy. So what happens is, this TGF beta release and VEGF are something which we encounter normally also. Why is it problematic? Because it is released in excess. There is also generation of reactive oxygen species. There is also increase of the procoagulant activity on the endothelium as well as the macrophages. And there is extracellular matrix synthesis. Now, in total, because all these reactions occur in excess, the end result is vessel wall injury as well as microangiopathy. These are the receptor mediated effects. Now, AGE doesn't need receptor also. There are certain non-receptor mediated effects that it can cause. When AGE binds with type 1 collagen, it would lead to endothelial injury. When AG binds to type 4 collagen, there will be decreased endothelial adhesion and increase in the extravascular fluid release. There will also be accelerated atherosclerosis. Why does accelerated atherosclerosis occur? Because in large vessels you will have a protein called as LDL. Now this LDL, it tends to get trapped because of AGE. When this LDL gets trapped, there will be no efflux of LDL from the large vessel wall. So no efflux of LDL will lead to what? Cholesterol deposition in the cardiac intima. So that will increase the chances of formation of atherosclerosis. The second mechanism is activation of protein kinase C. So protein kinase C activation as well as its secondary messenger, which is your diacylglycerol activation is very normal. But what happens in hyperglycemia? In hyperglycemia, there will be increase of diacylglycerol. So what will that do? It will activate your protein kinase C even further. So what happens? There will be increase of VEGF, increase of TGF beta, like we saw in the first mechanism. So what that leads to? In total, that leads to diabetic microangiopathy. The third mechanism is oxidative stress and disturbances in the polyol pathway. Now, what happens is, because of hyperglycemia, glucose tends to go intracellularly into tissues which it doesn't usually go to. So that would be like nerves, brain, etc. Now, in a normal condition, this can be resolved by NADPH. So what NADPH does? NADPH metabolizes this glucose into fructose. This uses a cofactor called as GSH reductase. Now this GSH reductase, what it does is it converts it into reduced glutathione. Now this reduced glutathione or GSH, it will decrease the oxidative stress and ensures that there is this intracellular glucose gets converted into fructose. Now what happens during hyperglycemia? There will be decreased GSH reductase. That is, this tends to get decreased. So then what happens? If this tends to get decreased, there will be formation of something called as sorbitol. And this sorbitol tends to get deposited into eyes, nerves, etc. So this, because I said it gets deposited into the eyes, it increases the formation of cataract. And the last mechanism is hexosamine pathways and generation of fructose 6 phosphate. So here what happens is, this has increased flux of metabolites. This pathway has increased flux of metabolites because of hyperglycemia. So then what happens? The cells usually tend to get damaged. Cell damage occurs. After understanding the pathogenesis of what underlies these complications, let us now look at the morphology of these complications. I'll debunk this entire flowchart from a pathologist's perspective by showing you in the forthcoming slides how these complications look under the microscope. The first is diabetic macrovascular disease. So in diabetic macrovascular disease, you will see the manifestations in two places. One is kidney or the renal hyaline arteriosclerosis, and the other is atherosclerosis of the coronary arteries. So in renal hyaline arteriosclerosis, as you can see here, the renal vessel wall will be thickened. That is why it is called as hyaline arteriosclerosis. As you can see here, there is a thickened vessel wall of the kidney. In atherosclerosis, what happens is, in the coronary arteries, like we had discussed before, because of the deposition of LDL, you will see that there will be decrease, that is narrowing of the luminal space. The lumen is narrowed, and because of the deposition of LDL, there will be formation of cholesterol intima that would lead to atherosclerosis. So the second manifestation is the one that occurs in kidneys, which is called as diabetic nephropathy. Now in diabetic nephropathy there are three major lesions that are formed. One is glomerular lesion. So what happens is there will be pinkish or like eosinophilic deposits in the glomeruli of the kidney due to diabetes, which are called as Kimmelstein-Wilson lesions. They are called as Kimmelstein-Wilson lesions, that is eosinophilic deposits in the glomeruli. The second is, as we had seen in the previous slide, there will be hyaline arteriosclerosis of the renal vessel wall. And the third is pyelonephritis. So what happens in pyelonephritis? Because of any infection or because of bacteria primarily, there will be inflammatory infiltrates in the kidney, which is called as pyelonephritis. So this is the renal tubules, which is highlighted by the past tape. So as you can see here, there is thickening of the tubular membrane. As you can see here and here, there is thickening of the tubular membrane highlighted by the past tape. The other is sclerosis of the mesangium. So as you can see here and here, there is diffuse mesangial sclerosis, also very common in diabetes mellitus. The other complications are ocular complication. In ocular complication, like we saw before, very important complication is diabetic retinopathy. The other common complication in diabetes due to diabetes can be glaucoma. The next is diabetic neuropathy. Almost 50% of the patients who have diabetes mellitus are subjected to peripheral neuropathy. So I hope you enjoyed this video lecture series on diabetes mellitus. In the first video, we discussed in detail about glucose homeostasis. In the second video, we've covered an in-depth discussion about type 1 and type 2 diabetes mellitus and their differences and pathogenesis. And in this video, we've covered the clinical features of diabetes mellitus and also its complications. If you like these video lectures, please like and subscribe to my YouTube channel and share this with whoever is in need of this information. So I hope this is useful to you, and we'll see you in the next video lecture series, because knowledge shared is wisdom gained. Bye bye.